Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms, Marcus at home welcomes in Sydney, Australia, Dr. Bruce Neal, with whom we would like to discuss the cardiovascular implications of a reduced dietary sodium intake. Bruce, it's a pleasure and an honor for us to have you this morning. Thanks for taking the time to be with us.
Oh, it's a pleasure. Thank you.
So Dr. Neal is director of the George Institute in Sydney, New South Wales, and he's professor of internal medicine at the University of New South Wales, again in Sydney. He has published numerous papers in the field of kidney disease, hypertension, to name just a few of them. He did the CANVAS study, the Credence study on the prognostic implications of SGLT2 inhibitors, and some weeks ago, he presented at the annual meeting of the European Society of Cardiology, one of the most important studies of this year, I guess, the SSASS study that assessed the cardiovascular implications of substituting potassium for sodium salt. My co-moderators today are Dr. Andreas Kronbichler from Innsbruck and Cambridge, and Stefan Schermer from Kaiserslautern in Germany. My name is Gunnar Heine from Frankfurt, Germany.
Good morning, Dr. Neal, from my side. Also, let me allow me please to start with a few questions just on the general design of your study, which really shook us a little bit at the ESC because it was one of these studies, no pharmaceutical intervention, just some lifestyle thing, and actually getting hard endpoints reduced. So what was your aim? We all discussed in cardiology for a while already the implications of salt and salt intake on high blood pressure, and whether we recommend to reduce salt to reduce blood pressure, but just let us know, what was your goal? What was your aim in doing this large study?
Yeah, so thanks. I'm a great believer in randomized trials, and as you made the comment in the introduction, I've been involved with a series of drug trials, but I believe that we should have similar quality evidence about dietary and lifestyle type interventions. And the goal with this study was to try and achieve that. So it was to say, we're interested in sodium reduction. There's all sorts of observational epidemiology out there. There's lots of small trials looking at blood pressure outcomes, but what we really need to convince clinicians, public health physicians, and perhaps even the food industry is large-scale randomized evidence that defines effects on things that clinicians, policymakers care about. So strokes, heart attacks, and ultimately death, of course.
Thanks. And then you had a very, peculiar design somehow in randomizing not participants of the study, but actually areas or villages in China. Let us know how you got to that design.
Yeah, so we did a cluster randomized trial. So we had 600 villages and we randomized at the unit of the village, but we had 35 people who were at high risk in each village. And the downside of cluster randomizing, of course, is that you lose some statistical power. Although if you randomize 600 villages, you actually don't lose that much power. But the advantage of it was that we could deliver the intervention, which was providing a free supply of salt substitute, to a group of villagers who were living in one place. Whereas if we delivered salt substitute to some but not to others, then it would have been difficult because they might have shared the salt substitute. They might have been feeling a bit bad that they got the salt substitute, but their friends didn't, or vice versa. So it was a sort of practical solution to the problem. That was why we did it in a cluster randomized design.
But you could manage to use inclusion-exclusion criteria. From what I got from the manuscript, they wasn't all so strict. No kidney function tests at all, or?
Yeah, so we wanted so you're getting to the sort of one of the key reasons why salt substitutes haven't been widely used, which is this concern about the risk of hyperkalemia. That is obviously something that is primarily of concern in people who have got seriously impaired kidney function or who are using potassium-sparing medications of some form or another. So we had very little money to do this study. We did the whole study on probably $7 or $8 million, 21,000 people, 5 years, providing the salt substitute. So we were not in the position to be able to test everyone's kidney function or potassium levels when they came into the study. But equally, we made the case to the ethics committees that if people had kidney impairment sufficient to make risk of hyperkalemia substantial, they were already likely to know about it, and they're not meant to eat salt anyway. So we didn't test kidney function, we didn't test blood potassium levels, and as we'll come to, I guess, when we speak about the results, we didn't see any increased risk of hyperkalemia. But the end consequence of this is that we have a result that is potentially highly generalizable. It's not a clinical intervention because it doesn't mean it can't just be delivered to people who've had a blood test. It becomes potentially a population intervention, which was again a main intent of the trial.
Interesting. And speaking of how to get to the villages and the people, how did you I mean, when I read through the beginning of the results now where we're coming to, I think you wrote 100% vital status known. That's excellent, even in a large pharmaceutical study involving a lot of money. How did you actually manage to get hold onto all these people, these villages in rural areas, as I understand?
Yeah, so we went to villages in rural areas because, again, for a practical reason. In those villages, most people are eating most of their salt from salt that they add when they cook in the home, so it's quite easy to replace a significant proportion of their daily sodium intake. But how do we do it? Well, I mean, I've had the privilege of working with colleagues in China for the best part of 25 years. I think we did the first pilot study probably 15 years ago. So we had really strong collaborations with both the local researchers and the local government. In terms of the completeness of follow-up, we were able to leverage off a rural health insurance scheme. So there's a sort of form of universal healthcare coverage in China, which means that if you live in a rural area and you go to hospital, if you're part of the insurance scheme, you get a large proportion of the costs of that hospitalization paid. And what that means is that you have almost complete uptake of people who join that insurance scheme. And that meant that we were able to get very complete follow-up for non-fatal events. And then there's also a pretty good mortality surveillance scheme in the region too that we were also able to leverage. And that's why we were able to get that very complete follow-up.
Great. So tell us about the results. You already alluded to some very hard endpoints and then the softer, well, not so soft endpoints. They were all adjudicated by the hospitals. And what did you actually find out?
Yeah, so we specified one primary endpoint, 2 secondary endpoints, and 1 safety endpoint. So the primary was stroke. We chose stroke because it's the most blood pressure sensitive of all the cardiovascular endpoints, and we saw a 14% reduction in the risk of stroke with a highly significant p-value 0.006. And we recorded over 3,000 stroke events during the study. For the 2 secondary outcomes, the first of those was major adverse cardiovascular events, defined in the usual way. 13% reduction in that, p-value of less than 0.001, and about 5,000 events recorded in the study. And for mortality, a 12% reduction. Once again, p-value less than 0.001, so very clear results. And about 4,000 of the study participants died during the study. Participants were older and at high risk. They were mostly people with hypertension or a history of cerebrovascular disease, hence the high event rates and the high mortality rate. So really clear evidence of benefit for the primary and the 2 pre-specified secondary outcomes. The third, the safety outcome we pre-specified was hyperkalemia. That was clinical hyperkalemia events. We didn't test blood potassium levels, so it's quite possible we have missed biochemical hyperkalemia, but we saw no evidence of any increased risk of hyperkalemia. There were far fewer events, only about 300 or so, but a hazard ratio of 1.04 and a p-value of 0.76.
Thank you. The hyperkalemia issue is, for me, one of the most interesting issues, probably for a nephrologist as well. So I'd hand over to Dr. Kronbichler. Thank you very much.
So good morning and good afternoon from my side as well. I'm here now to discuss some of the questions related to the study. So the first one, is there any explanation why in SSASS the salt substitute group had a significant drop in systolic blood pressure, while this diastolic blood pressure did not change during the follow-up?
Yeah, look, I think that is probably because it was mostly an older population. And if you look at trials of blood pressure lowering, even mostly what you see in older populations is a substantive fall in systolic blood pressure, but often not a corresponding fall in diastolic blood pressure. So I'm not sure I can provide you with a good pathophysiological rationale for it, but I wasn't surprised when I saw that in the trial result.
Looking at the subgroups, I observed that the effects seen in SSASS seem to be more pronounced in women than in men. Do you have any explanation for that?
Yeah, so when you actually test for any evidence of heterogeneity between the subgroups that we looked at, I think the p-values are all greater than 0.2. So I don't think there is actually any strong statistical evidence of heterogeneity between men and women. And so our assumption had been that, that variation was probably the consequence of chance rather than any real difference in effect.
And one final question from my side. I mean, looking at other trials you have done in India and hypertension, you did the SEALS trial and you indicated that there was an average urinary salt excretion of 10.4 grams per day at baseline. So my question is rather practical. What is your screening measure, the ideal screening measure to detect a high sodium intake in individuals?
Yeah, so it's really hard, as I'm sure you would be aware. Trying to get people to do 24-hour urines is not something that you take on lightly, either as a clinician or as a patient. So to be honest, I wouldn't be advocating that we screened people on the basis of their sodium intake before deciding whether they would benefit from salt reduction or from a salt substitute. We've done, quite a few meta-analyses, systematic reviews, and it does look as though the effects of salt reduction and indeed salt substitution are probably generalizable across people with a range of different baseline blood pressures, a range of different levels of sodium and potassium intake. So I don't think it's actually necessary to do that, and I wouldn't be advocating for that. I'd also add that I don't think that a sort of spot urine based estimate using an equation is going to be a particularly good way of trying to work out for an individual what their level of intake is, because those equations were really intended for estimating population levels, not individual levels. So there would be a lot of random variability in that, I think.
So when looking at these meta-analysis, and you did one just last year in the British Medical Journal, then you would actually expect a somewhat lower reduction in blood pressure given these real-life results that you had. I think you reduced the sodium intake by around about 20 or 25 or so millimoles. So I think there's also a second component, this increase in potassium intake, which you had at the same time. Would you just give us some idea about that?
Yeah, absolutely. So, I mean, it's very clear from the observational epidemiology that potassium as well as sodium is a determinant of blood pressure. So the more potassium you eat, the lower your blood pressure is. And there are multiple randomized trials that show that if you supplement dietary potassium, you get a blood pressure lowering effect. The question that you're asking is a question I've been asked many times. Was this a sodium reduction effect or was this a potassium supplementation effect? I'm pretty sure it was a blood pressure effect. That was what we designed the trial on the basis of. If we got 3 millimeters of systolic blood pressure lowering, we would get about a 14% reduction in stroke risk. But what drove the blood pressure reduction? I'm sure that's a combination of both the sodium reduction and the potassium increase that we achieved. We are embarking on some additional analyses to try and figure out what proportion might be attributable to each, but I don't have a good answer to that right now, I'm afraid.
When we went to medical school, so last century at least, we heard a lot of salt sensitivity and stuff like that, and we kind of subdivided people who have some kind of salt sensitivity and others who don't. Does this idea still hold true, or should we consider everybody as kind of salt sensitive?
Yeah, so that's a really interesting question as well, and I have to say I've been a bit skeptical about the whole salt sensitivity piece, and the reason for that is that you measure blood pressure very imperfectly at an individual level, and people look sensitive or insensitive to salt. Probably not because they are truly sensitive or not sensitive, but rather because you just happen to measure them chance high or chance low at baseline and follow up. And so you sort of artificially introduce apparent sensitivity simply as a consequence of measuring blood pressure badly. We actually did some analyses of this looking at the effects of blood pressure drugs, where there's the same sort of view of clinicians, which is that some people respond really well to a drug, some people respond less well. And we did some quite interesting sort of maths on this, where you can look in a randomized trial and you can see what's the apparent variability to the drug, but then you can also look in the placebo group and you can see how much does the response to the placebo vary. And of course, the response to the placebo is only error in measurement of blood pressure. And mathematically, you can actually subtract that error away from the error that's in the actively treated group. And what it shows is that something like 90% of the apparent variability of an individual's to a drug is just chance. Most people actually respond just the same way. That's not how it looks in clinical practice, and it's not what everyone believes, but that's almost certainly truth. And I think the same is true for sodium. So I think probably the effects of sodium on blood pressure are much more widely generalizable and much more constant than people actually think.
And then there's a lot of intellectual discussion about some potential adverse events of low salt diet, such as activation of the renin-aldosterone system, or also maybe reduced insulin sensitivity and changes in lipid levels. So apparently this is not of clinical relevance if one looks to your results.
So I've been a little skeptical about some of the epidemiology. I mean, some of the sort of the J-shaped and the U-shaped associations that we see are almost certainly the result of confounding, probably by sort of reverse causation, you know, people who've got disease, eating lower salt, but not reversing their risk fully. There's also been some recent complications because people have been using some of these equations to estimate sodium intake and then associating that with subsequent risk. And the problem there is that the estimating equations for going from a spot urine to a 24-hour urine include things like age, gender, BMI, all of which have their own associations with risk. And so the association that you see at the end is assigned to the estimated 24-hour sodium, but actually it's probably being driven by a whole bunch of other things. And there's been some quite elegant analyses that have suggested that's introducing significant confounding. The stuff about sort of activation of the renin-angiotensin-aldosterone system has particularly been when you've got really acute reductions in sodium, or when you've got reductions at very low levels. Frankly, we didn't test that. I mean, we tested a moderate reduction in sodium at an average level of intake. So personally, I think it's unlikely, given the totality of the evidence, that sodium reduction is going to be harmful. But does SSASS absolutely exclude that? No, it just doesn't answer that question.
So when it comes to clinical implications, at least here in our unit, we try to have 24-hour urine collections once a year or so in outpatients to get some idea of the changes in dietary uptake. Would you recommend us to continue to do like that, or would you recommend more often 24-hour collections in stable outpatients? What are your ideas about that?
Yeah, so I should say right now I'm not a practicing clinician any longer, so I take a rather epidemiological and sort of public health perspective on this. My sense is that sodium reduction is likely to be beneficial across the board for a diverse range of people, irrespective of what their sodium intake is. So, one of the things that I like about the SSASS result is that I think probably pretty much anyone who eats salt could switch to a salt substitute. And unless they've got really serious kidney disease, they're likely to benefit from it. They might not benefit very much if they're not eating a lot of discretionary salt that's replaced by the salt substitute, but they're much more likely to benefit than harm. From a clinical perspective, I think salt substitutes are also attractive because, when I did practice, I used to tell people to eat less salt, but it's impossible. You've got to change your lifestyle. People aren't really able to do it. Most of the salt is packaged up in discretionary in packaged foods. It's very hard to actually do. A salt substitute is a very easy thing to use. I mean, all you're doing is switching one crystalline white powder for another crystalline white powder. You use it in just the same way. You don't have to make any change to your lifestyle. Otherwise, it's not very expensive. So I think there's a nice clinical opportunity there for physicians to go, here's something that I can actually expect will change your sodium intake, and I know that it's likely to benefit you, not to harm you.
So one last question from my part, and then I'll hand the mic back to Stefan. You explained to us why you went to China, and surely this would not work in Sydney or Melbourne, where most people get their lunch and their dinner in restaurants or whatsoever. Do you think that this might also have worked in some rural areas in Australia or Europe, or may there also be some ethnical background behind it that may affect the way that salt and salt substitute may drive blood pressure?
Yeah, so we went to China only because it was a good place to test the hypothesis, not because we felt that this was only going to work in people of Chinese ethnicity. I mean, my sense is that the basic physiology underlying sodium, potassium, blood pressure is highly conserved across all sorts of populations in the world, and older people, younger people, people with disease, without disease. So I believe that the underlying fundamental result here is almost certainly highly generalizable. Of course, the benefit that you'll get from a salt substitute will depend entirely upon how much of your dietary sodium you can replace with a salt substitute. And in somewhere like rural China, much of Africa, much of Latin America, that's probably a really significant proportion, probably more than 50% of your daily sodium intake. In Australia, it's probably more like 15%, and probably the same in Germany and most countries in Europe. So direct substitution of salt with the salt substitute in higher income countries is likely to be less effective. But I hope that there might be a message in here for food manufacturers and retailers as well, and that they could stop adding so much sodium to products when they process them, and try not to leach out all of that potassium that is in the fresh product before they start processing it. So I think that's probably where the primary implication is for higher income settings.
You already just alluded to what I was going to ask you. Now we're going into the more broader view, food companies. What's your what have you been observing already? Have you got any contacts? Do you see any large companies, and in the discussion, have you seen any change in behavior at all? I mean, they're not going to sit down and read the New England Journal every week. So what do you think will be happening? We've been seeing sugar restrictions on an international level, and policy pressure also. What can politics do?
Yeah, so it took the best part of 20 years to sort of get this study up and funded and done. I think there's at least 10 years more work now in actually getting some translation. But to your point, what I'm thinking is that we need now to put together a program that includes not sort of epidemiologists, but includes policy analysts, business analysts, health economists. And what we need to be, what my vision is that we would be able to set up a group that would be able to help countries work out what would be a way to get salt substitute taken up widely in the country. And so, for example, in China, where we did the study, we've engaged closely with government and salt manufacturers throughout. The situation in China is fairly unique in that salt manufacture is largely government controlled, and government can control the price. So we're already talking there with the salt manufacturers about trying to switch from producing just regular salt to producing salt substitute at scale. Price will be important, because even though it's a low-cost commodity, if you go to a really low-income setting, then even a 50% rise from $1 a kilo to $1.50 a kilo can be important. So I think we'll be advocating hard for subsidization to the same price. And then there are also a series of initiatives around things like labeling, health claims, that we can also look at as ways of trying to get uptake. Of course, the circumstances are going to vary from one country to the next, and we want to be in the position to develop a tailored solution for each different jurisdiction, depending upon what the opportunity is.
One last very not scientific question. We didn't talk about the taste of that salt at all, because it's actually the first thing I'm always asked when I report about your results, and people are afraid that things mightn't taste good anymore. Can you assure people, would we have to do a broad salt tasting first before really convincing everybody?
So one of the reasons we chose this mix of salt substitute, which is still 75% regular salt and 25% potassium chloride, is that we knew from prior testing that we'd done that it was very well tolerated. There is a tiny detectable difference in taste, but it's not that it tastes terrible. It just tastes a bit different, and you can get used to it very quickly. And I mean, one of the striking observations at the end of the study was that 90% of the people who were assigned salt substitute were still using it at the end of the study 5 years on. I never get adherence like that in a drug trial. So I think it's an incredibly well tolerated intervention. So I don't think taste will be a big issue.
Thank you.
So thanks a lot for taking the time for being with us and for particularly driving this very important study. We just learned that you're about to start the next big study on very early SGLT2 inhibitors in patients with new onset diabetes. And we're thrilled to read about that in 10 years or so when the study will be done. Until then, thanks a lot. And it was a pleasure to have you, and have a good evening in Sydney. Thanks, Bruce.
Look, thanks very much. And really interesting interview and great questions.
Thank you.
Have a great day.
Thanks.
Bye-bye.
Bye-bye.